Hello, dear students. Please uh, confirm whether I am visible and audible. Yes, I guess I am visible and audible. So, if there is anyone who is watching this video, please do confirm that both my audio and video are working fine. Okay, I guess I can hear my voice. So, welcome, student. This is going to be a video which we are going to discuss methotrexate for the dermatology postgraduate residents. So a very warm welcome myself, Dr. Maddineni Srinivas. If you are unaware, uh, if you are new to this channel, myself, I am a dermatologist and I make videos for the undergraduates as well as the postgraduates pertaining to dermatology related content. So I can see, thank you so much. General category, yes, I am visible and audible. Thank you so much for the confirmation. Right, you can remember me as Maddineni Srinivas, dermatologist. So MS Dhoni, MSD, DrMSD. So in this video, we are going to see the practical tips for the usage of the drug. So this methotrexate, it is having so many indications. So routinely we are going to use it for psoriasis that you might be knowing, but apart from this there are many other indications. So we are going to discuss methotrexate in a detailed fashion so that at the end of this lecture you are going to have a different set of the rules and regulations and the concepts pertaining to the methotrexate, by the help of which you can remember what are the other indications and what are the mechanisms of actions of this drug helping in those indications. Okay, and why is it important for you to know this is because it is very cost effective medication. It's very cheap medication, unlike other medicines which are used in dermatology, which are very expensive. And also there are many advancements and updates which you need to be aware with relation to the methotrexate. So I will try to include those things also here. And yes, everyone uses this. All those who are using this medication day in and day out, please raise your hands or give a like for this video. And it is a safe medication only in the safe hands, because monitoring is very crucial while you are administering this methotrexate medication, because this is a teratogenic medication. Most important contraindication pertaining to this methotrexate. And also you need to remember there are various adverse effects pertaining to methotrexate which you need to remember. And there are so many misconceptions or myths related to methotrexate which I will try to bust in this video. And of course, apart from dermatology, in other branches of medical field also methotrexate is being used very routinely. Rheumatology, rheumatoid arthritis, this is used very routinely. And in gynec also for ectopic pregnancies and certain malignancies like choriocarcinoma, ovarian malignancy, this medication is very commonly used. So because of all these things, you need to have a clear cut idea. Yes, apart from this, in the theory and in the viva also, methotrexate is a very important drug which you need to remember. And these are all the sources from which I have taken the information. So I will leave the links for these in the description below. And let us begin our discussion of the methotrexate with just general basics. So I hope everyone is with me. Whoever is watching this video, please do give a confirmation in the chat section. Yes, please give a like or any kind of a confirmation that you are with me. And I try to make this two-way communication so that I want you to reply if any question is asked by me. If you are watching this as a recorded version, you can give the reply in the comment section of this video. Okay, so this medication methotrexate, it was initially introduced by the Ella Pragada Subbarao in Harvard Medical School, and it was called as amethopterin. And please remember, it is It is also called as aminopterin. And most important vitamin which you need to remember associated with methotrexate is folic acid. Methotrexate is a folic acid antagonist. It is a folic acid antagonist. That is the most important thing which you need to remember. And why is it so? Because methotrexate is structurally very similar to the folic acid. So if you look at this picture, you can clearly understand this. So this is the folic acid here. Above you have folic acid and below you have methotrexate. And you can see that the only two minor differences between folic acid and methotrexate are that we are going to have this amino group at the 4th position, and we are going to have this methyl group at the 10th position. So rest of the thing, everything is same except for these two changes. That is the reason why. What is the name of this methotrexate? It is also called as 4-amino, because at the 4th position amino group is there, and N10 methyl pteroglutamic acid. So this is the 10th position where methyl group is replaced. Apart from this, folic acid and methotrexate both are same. And what is the importance of this? What is the significance of this? There is one enzyme. There is one enzyme which is called as DHFR. What is DHFR? Dihydrofolate reductase. Dihydrofolate reductase. This enzyme is going to be having action on folic acid, and also in between, if methotrexate is there, that methotrexate is going to cause inhibition of this enzyme, thereby reducing its activity on the folic acid. We will see what it is going to produce and why is this enzyme important in the DNA synthesis. We are going to see that in the upcoming slides. But please remember, this methotrexate is an anti-folate medication, and it has potent competitive antagonist properties on dihydrofolate reductase enzyme. And remember, it has a greater affinity, even more than folic acid, for the dihydrofolate reductase. That means if methotrexate is there in the bloodstream, then that is going to be attaching to the enzyme DHFR more so than the folic acid, Okay. So I hope you might have seen this movie Dostana, which was released in 2008. So I hope you all know the hero heroines who are there here: Priyanka Chopra, John Abraham, and Abhishek Bachchan. So why am I telling you this? Is because in this context of methotrexate, you can remember that the Priyanka Chopra is like the dihydrofolate reductase, and John Abraham is the folic acid, and methotrexate is Abhishek Bachchan. Why am I telling you all this? But just give me some time. I will clarify why am I telling you this. But before that, understand this flow chart which you are seeing here. So the folic acid, the folate, it is ultimately going to convert into tetrahydrofolate, THF we call it in short, and this is going to convert into the purine, and ultimately this is going to produce the or help in the DNA synthesis. It will help in the DNA synthesis. Okay. So in this there are certain enzymes and certain molecules which you need to remember. The first enzyme the folic acid is going to be acted upon is the dihydroteroate synthetase, and we are going to have the drugs dapsone and sulfonamide. These are the two important medications, dapsone and sulfonamide, which are going to inhibit this particular enzyme dihydroteroate synthetase. So how can you remember this? So see here we have the alphabet S, and in dapsone we have the alphabet S, and sulfonamides we have this alphabet S. So that is how you can remember this step. Dihydroteroate synthetase is inhibited by dapsone and sulfonamides. Next, with this enzyme we are going to see the production of the dihydrofolate DHF, and dihydrofolate is acted upon by DHFR, dihydrofolate reductase, and it is going to be converted into the tetrahydrofolate, and this particular enzyme DHFR is inhibited by metho. So you can see here the methotrexate trimethoprim. So wherever you see this metho word, remember that is going to inhibit dihydrofolate reductase. This is very, very important for you to remember. And one more thing which I want to tell you is, so dapsone is utilized in certain neutrophilic dermatosis. I hope all of you know that. For example, in the case of dermatitis herpetiformis, it is used in the vesicular disorders, and also in neutrophilic dermatosis, sweet syndrome also this is used, dapsone. This can be used. So in such cases, remember, if we are going to shift the patient to methotrexate, or if you are going to add on methotrexate, then there is going to be a problem with the toxicity. Why? Because both of them are going to act on the same step, and they are going to inhibit the production of the tetrahydrofolate, which is very, very important in the DNA production. Particularly, remember, it is useful in the S phase. It is having a role mainly in the S phase of the cell cycle. So remember, this methotrexate is used in the case of neoplasias, various neoplasias, because it is going to inhibit the cell cycle of the malignant cells. It is also used in dermatology because, mainly because of its immunosuppressive action. So we will see the mechanism of actions in the upcoming slides. Okay. So I hope you have understood this. And why did we see this picture? So John Abraham, Abhishek Bachchan and Priyanka Chopra. Next slide I will show you. But here, if you observe carefully, on one end we have this folinic acid or leucovorin, very, very, very important drug. And if you observe carefully, it is bypassing the DHFR, it is bypassing the dihydrofolate reductase enzyme. So whenever any person is having the toxicity due to the methotrexate, we cannot use the folic acid. We cannot use the folic acid medication or the vitamin for the production of the normal DNA synthesis, but instead we are going to use the folinic acid. Why? Because the folic acid requires the dihydrofolate reductase activity. But as I have already told you, this methotrexate has a higher affinity to DHFR, even more affinity than the folic acid. So all the enzyme molecules will be bound to the methotrexate. So we are not going to have any conversion of the folic acid to the tetrahydrofolate, and this is very important for the DNA synthesis. Okay, I hope it is clear. And we are going to see where we are going to use the leucovorin and how much dosage we are going to use the leucovorin also in the upcoming slides. So here you can see this is the normal thing. This is the folic acid. So we are remembering it as folic acid, and this is the dihydrofolate reductase. So usually this will be the case where both of them will be in a bond form, and there will be normal tetrahydrofolate production. But whenever we are going to have the methotrexate, drug, it is going to have more affinity towards the enzyme DHFR. So there is going to be this folic acid which is not going to be converted into the tetrahydrofolate. So there will be a problem in the DNA synthesis, particularly S phase of the cell cycle. Okay. So this is one mechanism. This is basically one mechanism of the methotrexate. But apart from this mechanism, which is mainly used in the malignancies, for the treatment of malignancies, we are having so many other mechanisms which we are going to see in the upcoming slides. So most of this cycle flow chart, whatever I have taken the tables, they are from the Wolverton. You can follow that. Okay. So here is just a simplified version. Folic acid. We need the enzyme DHFR, dihydrofolate reductase, for the production of the tetrahydrofolate. Okay. THF. And in between, there is one more enzyme which you need to remember, which is TYMS, which is thymidylate synthase. And remember, the methotrexate is going to inhibit both DHFR as well as TYMS. And ultimately, there is going to be a reduced DNA production, DNA on RNA production. Okay. Now, few points related to some pharmacokinetics, pharmacodynamics. So, absorption and distribution. Whenever we have this methotrexate given orally, the absorption is going to be incomplete and there will be rapid absorption, but slow plasma levels will be reached. Slow plasma levels will be reached, and more as the time passes, there will be more reliable levels which will be reached. So what does this mean? So initially there is going to be absorption of the methotrexate medication, and in the tissues this is going to be converted into PGMTX. This will be converted into PGMTX. What is this? Polyglutamate methotrexate, which is going to be released into the bloodstream very slowly. So there is going to be a more reliable levels of the methotrexate medication. Actually, methotrexate is a prodrug. It is a prodrug. It is in an inactive form. So slowly as it gets converted into polyglutamate methotrexate, this is going to become the active form of the methotrexate, which is going to have its various actions on the cells. Okay. And concurrent food intake, especially the milk, if the individual is taking, it may reduce the bioavailability of the methotrexate medication. However, in adults, the drug is unaffected by the concurrent food ingestion. So this problem with intake of the concomitant milk and methotrexate is seen in the children. In the adults, this problem is not so routine. And the drug is well distributed throughout the body except in the brain. Why? Because methotrexate is very poorly penetrated through the BBB, that is blood-brain barrier. There is very poor penetration of the blood-brain barrier. So it does not reach the CNS in very easy way. Okay. Another thing which you need to remember, very important, is this methotrexate. It is going to be bound 50% to the plasma proteins. So what is the clinical significance of this? Whenever in the rheumatology we are going to use the methotrexate, usually in the rheumatoid arthritis. So in such case, because of the pain and inflammation, to reduce the pain and inflammation, concomitant usage of the salicylates will also be done. So in such case, what happens? These salicylates are going to bind to the plasma proteins, because of which there will be methotrexate which will be displaced from the proteins, plasma protein. So there is going to be higher concentration of the methotrexate in the blood, which can lead to methotrexate toxicity. So this is very important. And of course, the sulfonamides, they are also going to be bound to the protein. They are also going to be plasma protein bound. So whenever there is at the same time the patient is receiving methotrexate, salicylate, sulfonamides, and also tetracyclines and chloramphenicol, then there's going to be a higher chance of patient developing methotrexate toxicity, which is very important. We need to have an idea of this before we are prescribing the medication. And remember, the methotrexate, it is going to be excreted unchanged in the urine. Almost 95% is excreted through the urine unchanged. So why is it in what is the significance of this? Whenever we are giving any medication which is going to have a higher excretion through the renal tubules, like for example aspirin, probenecid, then there is going to be a competition between these two for the elimination excretion. Then if the aspirin and probenecid are given concomitantly, then the possibility of methotrexate to get precipitated in the renal tubules is going to increase, and the excretion is going to reduce, thereby increasing the renal toxicity and also methotrexate toxicity overall. So this is also one important aspect which we need to remember. So this we will see again in the drug interactions section pertaining to methotrexate. And remember, impaired renal function, if any person is having, methotrexate is not recommended. Most likely renal function impairment will be seen in elderly population or in individuals who are having diabetes mellitus. So this kind of patients, we have to be very careful when we are prescribing the methotrexate. Okay. So the methotrexate, it is written as 3 alphabets. Okay. MTX. So likewise, the this plasma levels are going to be having three important phases. So the first phase is going to be just less than 1 hour, 0.75 hours after the intake of the medication. There is going to be rapid distribution of the drug throughout the body. Rapid distribution is going to be there throughout the body. So that is one form of elimination, we can say, in which because of the rapid distribution, there is going to be this drug ready for the activity in the cells. Okay, and the next second phase is going to be renal excretion. I have told you that this methotrexate is going to be excreted 95% in the urine unchanged. So that is the next phase, and this is going to involve the glomerular filtration and active tubular secretion. So this is very important. So whenever there is any competition, so susceptible to drug interactions with weak acids, like for example salicylates, probenecid and sulfonamide. So there is going to be a competition between these two, and if these medications are in higher concentration, then there will be a problem with the excretion of the methotrexate, leading to the renal toxicity and also methotrexate toxicity. And then the third phase, remember, this is the terminal half-life, and it reflects a slow release of the methotrexate, which is in the bound form to the DHFR. Whatever medication is remaining in the body after the excretion through the kidneys, that is going to be in the bond form to the enzyme DHFR, dihydrofolate reductase, and slowly that is going to show its actions. Next, we are going to see the mechanisms of the action. So the first one, this slide we have already seen very detailed fashion in the previous slide. So methotrexate competitively and reversibly binds to the DHFR within 1 hour, within the 60 minutes span after the medication intake. This is going to be in the bond form to the enzyme, and it has a higher affinity than the DHFR than folic acid. We have already seen this, and of course we have seen this. And remember, tetrahydrofolate is crucial for the synthesis of thymidylate and purine nucleotides. So if you observe carefully here, the tetrahydrofolate in the presence of the thymidylate synthase will be converted into thymidylate, and ultimately that will be helpful in the formation of the DNA. Okay, these nucleotides are needed for DNA and RNA synthesis. Okay, this inhibits the cell division. So particularly it is S phase which you need to remember of the DNA synthesis Okay, additional inhibition of the TYMS. This also I have told you, thymidylate synthase is going to happen within 24 hours. That is 1 day after the administration of the methotrexate. And bypassing of the DHFR inhibition, we have already seen leucovorin, which is also called as folinic acid. And also there is one more thing, thymidine. So these two can bypass the DHFR inhibition. I will show you in the next slides how this bypassing of thymidylate is going to be happening with thymidine. Okay. Thymidine is converted. I will show you this. You can easily understand this. Yeah, this is the slide. So see, whenever we have this folic acid, it will be converted with the help of dihydroteroid synthetase into dihydrofolate, and the dihydrofolate, in the presence of the dihydrofolate reductase, it will be converted to tetrahydrofolic acid, and this tetrahydrofolic acid in the presence of thymidylate synthase will be converted into thymidylate, and it will ultimately form the purines and DNA. Those steps are not important. So what happens is, this methotrexate, it will not only inhibit the DHFR. So here we have DHFR, dihydrofolate reductase. It will also inhibit the thymidylate synthase. Okay. So whenever we have this methotrexate toxicity, so in the case of high levels of the toxic levels of methotrexate, we are going to use this leucovorin or folinic acid, which is going to bypass the DHFR enzyme, and it will act directly, and it will produce the tetrahydrofolic acid, and it will directly produce the DNA. There is not going to be any problem. And also there is one more molecule, which is thymidine, which is thymidine, and it is going to bypass the thymidylate synthase enzyme, which is again inhibited by the methotrexate, because this is going to act on the thymidine kinase and produce thymidylate directly, and we are going to get the DNA production without any problem. Okay, so these are the two molecules which you need to remember: leucovorin, most important one, and also thymidine. Okay, so that was the activity which we are going to use mainly in the neoplasias. And we also have this anti-inflammatory effects of the methotrexate. So there is a reasonably strong evidence that methotrexate has the anti-inflammatory effects, as it is going to predominantly increase the adenosine, very important molecule which you need to remember. It is going to increase the adenosine, thereby it is responsible for the anti-inflammatory effects. It is also going to reduce the nuclear factor kappa beta, thereby it is going to have anti-inflammatory activity. And remember, there is one very important enzyme which you need to remember: AICART, which is going to interact with the methotrexate, which is basically is inhibited by the methotrexate. Thereby it is going to cause the elevated adenosine levels, increase of the adenosine levels. And what is the full form of this particular AICART enzyme? Amino imidazole carboxamide ribonucleotide transformylase. So this is the enzyme which is inhibited, because of which there is going to be increased adenosine levels which will be noted, and this adenosine is going to have the anti-inflammatory properties. Because of this, we can use this medication in very low doses, and it is going to produce the anti-inflammatory effects which we are using in many of the autoimmune disorders. Okay, so this slide is going to help you to understand the methotrexate and its role in various conditions. So you can see here the methotrexate, which is a pro drug which we are giving. It will be converted into the active form, that is polyglutamate methotrexate. And what is the enzyme which is going to help in that? Folyl polyglutamate synthetase. FPGS is the short form used for this. So this is the enzyme which will act upon methotrexate and make this or convert this into the active form, PG methotrexate. And remember, this conversion of methotrexate to PG methotrexate is responsible for the longevity of the methotrexate, and this is also responsible for the weekly dosage schedule which we use for the methotrexate in dermatology. Okay, in other malignancies, oncology, the medication is used in very high doses, and that too it is used almost on a daily basis, but we dermatologists use it on a weekly basis. Okay, so here you can see this is going to inhibit the dihydrofolate reductase enzyme, so thereby there is going to be reduced synthesis of the DNA. Okay, and here you can see this has an activity on the AICART. Thereby ultimately what it is going to do, it is going to increase the adenosine levels, which has a anti-inflammatory effects. And you can also notice here that there is lymphotoxins are going to be reduced. Because of which the lymphoid cells are going to be having a reduced um, affinity towards the skin tissues. And what is the significance of this, you'll understand in the next mechanism, where we are going to have the immunosuppressive actions. I will show you in the next slides. So this is the one slide where you are going to see methotrexate. It will increase the adenosine levels, and also it will reduce the inflammation, because this adenosine has a anti-inflammatory properties. Okay, so yes, as I have told you, it has immunosuppressive effects. How does it suppress the immunity of the individual? So this basically depresses and inhibits CTLA positive T cell migration. CTLA positive, that is cutaneous lymphocyte associated antigen positive T cells. Okay, thereby what happens is there is going to be reduced migration of the activated T cells into the tissues. So in example psoriasis, the tissues are going to have elevated T cells, because of which there is going to be the pathogenesis. We are going to see that in the upcoming videos. Okay, the pathogenesis of various disorders, psoriasis also we are going to discuss. But this methotrexate, it is going to cause the reduced affinity of the lymphocytes to the tissues, particularly where there is excessive activity because of which there are psoriatic lesions produced. So thereby this is going to this methotrexate is going to have a immunosuppressive effect apart from the proliferation, anti-proliferative effects, because of the anti-folate like mechanism. Anti-folate like mechanism is also important, but remember methotrexate has a affinity for lymphocytes 1,000 times more than keratinocytes. This is very very important. This is taken from whole water. So we earlier thought that the mechanism on the keratinocytes by reducing the proliferation was very important, but now we understood that the activity on the lymphoid cells is also very very important. Why? Because methotrexate has effects on the lymphoid cells 100,000 times more than the keratinocytes. Okay, and so you can see here, thereby this inhibits the DNS, and this we all know already. And yeah, fine. Initially, yeah, it was thought to suppress the proliferation of the keratinocytes, which is responsible for the production of the silvery white scaly erythematous plaques over the body. But now we understood that it is also having a immunosuppressive effects, very very important. And methotrexate reduces the ATP. Methotrexate also reduces the ATP in the lymphoid cells, and it of course reduces the lymphotoxins, which you have already seen. It will also reduce the lymphotoxins, and likely it is going to act via immunosuppressive active mechanism, not anti-proliferative. So anti-proliferative is also important, but that is very important in the case of malignancies, not uh, these conditions which have mainly autoimmunity. In autoimmune disorders, immunosuppressive activity is more important than the anti-proliferative mechanisms. And what are the other minor mechanism of actions? So this is going to have an antagonism on JAK1 STAT3 and JAK2 STAT5 pathways. Thereby it is going to reduce the inflammatory cytokines. And it is going to cause anti-inflammatory cytokines elevation. What are those? Interleukin 4 and interleukin 10. You might remember these in various disorders. The interleukin 4 and interleukin 10 are associated. Okay, and of course, in the case of there are various indications for methotrexate apart from the psoriasis and Sézary syndrome, which are the FDA approved indications. So we'll see in the next slide what are those indications. But in those indications, like for example, in scleroderma and morphia, there is going to be inhibition of the collagenase synthesis. So thereby what happens? There is going to be increased collagen and there is going to be increased fibrosis in the tissues. So these are the tables which I am going to explain. These are from Wall Water, so you can go and check them out. So what are the FDA approved indications? Very important. Two of them, psoriasis and other one is Sézary syndrome. If you observe carefully, both of them have T cells in common. Psoriasis is autoimmune disorders associated with T cells, and Sézary syndrome is a cutaneous T cell lymphoma, which has now become a leukemic variant. So mycosis fungoides is a cutaneous T cell lymphoma, isn't it? But in the mycosis fungoides, the problem is only um, seen over the skin. It is not going to be seen in the bloodstream. But in Sézary syndrome, what is going to happen? We are going to see Sézary cells in the bloodstream. That is, it is a leukemic variant of the cutaneous T cell lymphoma. Okay, and also in Sézary syndrome, what else we can see? We can see SLE. What is SLE? Sézary cells. I hope everyone is able to understand. And we can see lymphadenopathy. Lymphadenopathy, and is a patient can go into erythroderma. So this is the SLE features which are going to see in Sézary syndrome. So these are the two FDA approved indications, but apart from that, there are very various other indications. Okay, so we are going to see the off-label. We call them as off-label indications. So just remember the headings. So if you can remember the headings, and the contents can be easily memorized. Otherwise, if you try to memorize all of them, all these indications, it will be very difficult. In the Viva, this is particularly important. So we can use in proliferative disorders, in immunobullous, vesiculobullous disorders, connective tissue disorders, we can use this, and vasculitis, we can use dermatitis. So these are the broad 5 main headings which you need to remember. So in the vesiculobullous disorders, you can remember pemphigus vulgaris, bullous pemphigoid, dermatitis herpetiformis. In all of them, we can use methotrexate. If the usual drugs, which usual drugs are steroids, cyclophosphamide, if they are not able to give the proper cure or manage the patients, then we are going to, or is there any contraindication, like the patient is having diabetes mellitus, hypertension, which steroids can worsen, then we can use a steroid sparing agents, like for example methotrexate. And in the autoimmune connective tissue disorders, so you can remember dermatomyositis, SCLE, SLE, systemic lupus erythematosus. Also, we can use methotrexate. Scleroderma. So I have already told you that it is going to cause inhibition of the collagenase synthesis. So this can also be used in scleroderma, morphia, and also in scleroderma diabeticorum. So these are all the indications, connective tissue disorder indications for methotrexate. And in the vasculitis, you can remember the leukocytoclastic vasculitis, Kawasaki disease, Behçet's disease, pyoderma gangrenosum, which is basically neutrophilic dermatosis. We can use this methotrexate. And of course, in dermatitis, atopic dermatitis is also one of the indications. Atopic dermatitis usually is seen in the children, isn't it? In the children. And remember, you might be wondering whether methotrexate can be given in children or not. But remember, in the adults, the dosage which you are going to use is 0.2 to 0.3 milligrams per kilogram per week. Okay, this whatever we are speaking is per week dosages. Whereas in the children, remember, methotrexate medication or any other medication in general, remember, they are going to tolerate the medications better than when compared to the adults. Okay. Yes, the dosage is going to be the more 0.3 to 1 milligram per kilogram can also be tolerated by the children per week. Of course, this is going to be per week. Remember, we as dermatologists are giving very small doses, very small doses. Whereas in the case of the malignancies, so in the case of the any malignancy, oncologists are going to give very high doses, because the mechanism of action which they want from methotrexate is the cytotoxic properties what they want out of methotrexate in malignancies. Various malignancies, lymphomas, ALL, and also it is used in choriocarcinoma in the case of gynecology. So various breast malignancies, ovarian carcinomas. So whatever it is, cytotoxic properties are the one which the doctor wants from methotrexate. But we dermatologists, we want immunomodulatory properties mainly. So we are going to use very low doses. That too, here you can remember, oncologists, they are going to use this as a daily dose, whereas we are going to use it once a week, very small doses. Okay, we dermatologists are very small. We require only small quantities. Okay, yeah, that is about. So atopic dermatitis, remember, we can use this medication safely if other measures, usually what we are going to use, steroids if there is any contraindication, or we have used steroids, but there is no any cure or manage, we are unable to manage with steroids, then we can also think of methotrexate as one of the safe alternative or a steroid sparing agent which can be used. And there are other dermatoses which can be used, but you can remember one of the other indications, that is keratoacanthoma. In keratoacanthomas, we can intralesionally give the methotrexate. This is very important for you to remember. Of course, this can be used in mycosis fungoides because it is a cutaneous variant of the Sézary syndrome. Sézary syndrome is a leukemic variant of the T cell lymphoma, and mycosis fungoides is one dermatological involvement only will be seen. Of course, this can also be used in the urticaria if the patient is not responding to the other medications. In alopecia areata also, we have seen the medication to be very much effective if the patient is not responding to the usual treatment. So in the psoriasis, remember, in general, 75 to 80% of the psoriatic patients who are treated with methotrexate respond typically, and the time taken is going to be usually 4 weeks. That is, we can say methotrexate takes some time for its activity to be seen clinically. So we can take it as 1 month. So if the patient is having psoriasis and if the patient asks you, sir, when can I see the difference between intake of this medication and my condition? So you cannot say that immediately after the medication intake you are going to have a dramatic relief. No, that is not going to happen. At least 1 month. At least 1 month is the time taken. In some lucky individuals, it may take 1 week. Okay, but we can safely say at least it will take 1 month for its actions to clinically be visible. And full therapeutic benefit you can expect the patient to have at least 2 to 3 months of the time. It will take 2 to 3 months of the time. So these are all the exact indications of the methotrexate in the psoriasis again. So whenever a patient is having erythrodermic psoriasis, whenever there is a patient having not only skin involvement but also joint involvement, that is psoriatic arthritis, and particularly if it is not responsive to the conventional therapies, that is, if we try to give some NSAIDs but still the patient is not having any proper response, we can give the methotrexate. And in the case of pustular psoriasis, generalized or debilitating localized variety. But remember, pustular psoriasis, the treatment of choice is going to be the retinoids. Retinoids, that is acitretin, which is used commonly. And about acitretin also, we are going to discuss in this type of a video format, in a lengthy format. So just subscribe to the my channel. So if you are not yet subscribed, and also do like this video if it is helpful. So next, psoriasis that adversely affects the ability to maintain the employment. That is, there is some social problems associated with this psoriasis condition. In such cases also, if even if the involvement is very minor, that is less than 10% body surface area, if it is involved, then also we can prescribe this methotrexate, because this is having its impact, it's causing embarrassment, or it's causing symptoms in other individuals in the society, which is causing a lot of difficulties in the employment. And also, if there is this extensive severe plaque psoriasis which is not responsive to the conventional therapy, that is, topical therapies have been tried but no, there is no use. In such cases, we can think of methotrexate because it is very easy to be used. It is very cheap. Any patient can afford this medication. Unlike the retinoids, acitretin, it is very costly. Everyone cannot afford this medication. Okay, then methotrexate is a very good drug which is available in the market in a very cheap price. Okay, and whenever there is lack of response to the phototherapy is a very good treatment modality, but the problem is that patient has to come to the dermatology clinic, office, or in the college, and they have to waste some time. I can say waste some time, because usually phototherapy we are not going to give in the night time. So in the morning time they have to leave the work whichever they are doing or the job, and they have to come to take the treatment. So in such case, or in the lack of response, or if there is lack of response to systemic retinoids, so in such cases also we can advise the patient methotrexate. But what are those conditions where methotrexate medication has to be has to be avoided. Remember, if the patient is diabetic, if the patient is diabetic and it is uncontrolled levels, or if the patient is obese patient, if there is obese, or in the case of elderly individuals, or if the person is alcoholic, or the patient is having some liver disease and some kidney disease. So in these particular patients, we have to be very, very careful while prescribing the medication. So we'll see what are the reasons for all these in the upcoming slides. Okay. So in the other conditions, what is the methotrexate dosage and any remarks? So let us see one by one. In the atopic dermatitis, so in the low doses also, in the very low doses also, this methotrexate can have a good clinical what improvement. And the problem is that it will take slower action. That is, it's going to take time. I have already told you, we have already seen in any condition, in psoriasis usually it will take 1 month. So in other conditions also it will take some time for the clinical improvement. So that is one problem. In alopecia areata, it will be helpful in the induction of the hair regrowth, and it is adults who are more responsive to this methotrexate. Okay, in usual small patches of alopecia areata, we can give intralesional steroids with triamcinolone. But in the case of the patient is having alopecia totalis, where the hair or the scalp is not gone, or if the patient is having alopecia universalis, when all over the body there is a loss of hair, then in such cases we can try methotrexate. And in the lupus erythematosus, we can see there is going to be a good skin as well as joint control improvement in the symptoms. But there is one problem. If you remember, we have seen that methotrexate is excreted through the urine 95% in unchanged form. If the person of lupus erythematosus has nephritis, that is lupus nephritis, which is very, very important involvement in SLE, then we have to be very, very careful, or better to avoid the methotrexate in such patients. Okay. And of course, in scleroderma morphea, we have seen that if the person is having skin and also joint involvement, we can happily give this methotrexate. In the dermatomyositis, remember, if the patient is having the skin lesions, what can be the skin lesions? Heliotrope rash can be there, the V sign, the shawl sign, a Holster sign can be there. And what else can be there? The patient. So these are all the skin changes which can happen where there is going to be violaceous macular erythematous changes over the body. So in such case, methotrexate can be happily used. Okay. And also dermatomyositis, the proximal muscle weakness can also be there. And also the patients may have the lungs, the pulmonary involvement. So in the dermatomyositis, remember, if the skin involvement is there in such cases, and in the muscle involvement, methotrexate is going to be helpful. Whereas if the lung involvement is there in the dermatomyositis, then methotrexate may not be very much effective, and you should remember that methotrexate itself can cause pulmonary fibrosis, so which can also occur in the dermatomyositis. So we should be very, very careful while prescribing this to the patients. And in PRP, we have seen the proliferative disorders apart from psoriasis, PRP, lichen planus. Also, this medication can be used in the pityriasis rubra pilaris. Remember, we usually use the acid retin, that is the retinoids. In the individuals in whom we are not getting a proper response, we can use the high doses of the methotrexate in combination with the acid retin. Okay. And also we can use this in PLEVA and PLC. The good news is that even in the low doses, this is going to be effective. Methotrexate. And coming to the contraindications, if the patient is having hypersensitivity to the methotrexate, obviously we should not give. And in the alcoholics, the problem with the alcoholics is that there is going to be damage of the liver. There is going to be damage of the liver. And whenever there is methotrexate usage, remember, it can produce the liver cirrhosis. And just imagine if a person is already liver fibrosis, sorry, and the patients who are having this alcoholic alcoholism, this alcoholism can produce the liver fibrosis and also liver cirrhosis. So in that is the reason why in such individuals we have to be very cautious, or better to avoid. If the we cannot if we cannot rely upon the person saying that, sir, I will stop alcoholism from today, if you say to stop. So in such patients also, it is better to avoid usage of the methotrexate and find any other alternative medication. Okay. And of course, remember, methotrexate has the cytotoxic properties, and it is going to cause reduced the cells in the blood. So blood cell counts are going to reduce. It can produce pancytopenias. So remember, if there are pre-existing blood dyscrasias, then we have to avoid usage of the methotrexate. Okay. So reduced hemoglobin, WBCs, platelets. If the patient is already having these problems, avoid methotrexate. Okay. And of course, this is a latest guidelines are going to say not as a category X drug, but latest guidelines say this methotrexate is a contraindicated in pregnancy. It is contraindicated by because it is teratogenic medication. It is a teratogenic medication. Okay. Immunodeficiency syndromes also, methotrexate should be avoided. Why? Because this itself can cause immunosuppression. So in the individuals who are already having this immunodeficiency problem, if we again give this methotrexate, it is going to suppress the immunity even further. So we have to avoid this. It is contraindicated in such individuals. And remember, the active form, that is polyglutamate form of the methotrexate, is going to be produced in the liver. So if the patient is an alcoholic, or if there is a problem in the liver, then the active form of methotrexate is not going to be formed as much as we want. So there is going to be reduced activity of the methotrexate which we are going to give, and this methotrexate will be not converted into PG form, and it can cause further toxicity. Okay. So that's why if the person is alcoholic, or if there is a obesity, we have to if the person is obese, we are not going to give the medication. But if the person is putting on the weight, then we have to further monitor. While monitoring, we have to advise the patient weight loss. But if we are seeing that the weight loss is not happening, then better to stop the methotrexate and find the alternatives. And there are various warnings. So most important one which you need to remember is hepatotoxicity. Obviously, already methotrexate is going to produce the liver fibrosis. It can also produce the liver cirrhosis. So in such cases, remember, if the patient is already having some liver problem, we have to not give methotrexate. And in the pregnancy also, this is not going to be used. Obvious, it is a teratogenic. Opportunistic infections can also occur because this can suppress the immunity, methotrexate. Okay. And in certain malignancies, it was observed that there is going to be a increased preponderance to lymphoma, certain lymphomas. So whenever methotrexate is used, and if a patient develops a lymphoma, remember, if we stop or if we decrease the methotrexate dosage, the lymphoma is going to regress. It is going to regress. um, and we have to stop the methotrexate if the patient develops the lymphomas. Okay. And of course, bone marrow suppression, we all know that this can produce the pancytopenia. And remember, the pulmonary fibrosis is also very important complication or adverse effect of the methotrexate. Okay. Especially in the patients of rheumatoid arthritis. And remember, gastrointestinal adverse effects, this can produce nausea, vomiting, abdominal pain, diarrhea, ulcerative stomatitis, intestinal perforation. Okay. And there is one thing which was observed: radiation recall phenomenon. So it is called radiation recall phenomenon, in which I will give you an example. If a person has a skin condition, Skin condition, for example, any malignancy for which radiotherapy was given, because of which the skin lesion has reduced. Okay, now if the patient is prescribed methotrexate for any other cause, then it was observed that the previous skin lesions which for which radiotherapy was given, now they are showing features of dermatitis. This is what is called as radiation recall phenomenon. Radiation recall phenomenon is associated or seen with methotrexate. Methotrexate. What are the precautions we have to take? This slide is very important. Why? Because the investigations which we have to do for the monitoring or before starting at the baseline of the medication are all dependent upon these slides which you have talked about in the previous, and this slide is very important. Okay, please remember the infections. Whenever there is a possibility that the patient might be having hepatitis B, hepatitis C, always we have to screen these infections before the initiation of the methotrexate. Why? Because they are going to damage the liver. So if the patient is already having this infection and again we are going to suppress the immunity, so this is going to increase the possibility of fibrosis, cirrhosis. So again that is going to produce a problem of liver cirrhosis going into the end stage where the entire liver is going to be useless. So that's the reason why we have to do the screening of the hepatitis B. And also tuberculosis. Reactivation of tuberculosis is a very important concern, particularly in India, where Mycobacterium tuberculosis is very rampant everywhere. And also one more thing is the tuberculosis can produce the lung involvement. So this methotrexate can also produce a pulmonary fibrosis. So that is the reason why before initiation of the methotrexate, always we have to advise chest X-ray and we have to see Mantoux test. Mantoux test. What are the findings we have to observe? If it is more than 15 millimeters, then we have to suspect the patient as having tuberculosis, pulmonary tuberculosis. Better to refer the patient to the pulmonologist and rule out any remote possibility of the pulmonary tuberculosis, and then get the clearance and then start the methotrexate. Otherwise better avoid or find any alternative. And also there can be possibility of opportunistic infections and live vaccines during methotrexate. Please remember, the live vaccination should be avoided. No live vaccine with methotrexate, and there should be a 2 to 4 weeks of interval, at least 1 month we can say gap between the stoppage of the methotrexate or initiation of methotrexate and the live vaccination. Okay. And if the patient is asking advice for killed vaccine, like for example a flu vaccine, then it can be given along with the methotrexate. There is no problem with the killed vaccine. And cutaneous, we have seen what is this radiation recall. uh, Hematologic, yes, we all know this is intended for weekly usage in dermatological practice. Severe toxicities, if daily dosing is given, which is seen in oncology practice, then there is a possibility of this problem of hematologic toxicity causing pancytopenia. But weekly dosage usually is not going to produce this pancytopenia. Okay. And you can see here the hematologic reactions are going to reduce with the usage of the folic acid. Very, very important. At the end, again, I will show you one slide particularly related to folic acid. So there are various schools of thoughts pertaining to the usage of folic acid. Uh, but what we routinely do is to be on the safer side. We can use higher doses of folic acid. That is even 1 milligrams is used by a certain dermatologist, and certain dermatologists also use 5 milligrams per day, every day, except for the day where the patient takes methotrexate. This is one school of thought. Okay. And I would prefer this one over the 1 milligram every day. Or there are other schools of thoughts where 5 milligrams is given once or twice a weekly. But what is wrong with giving folic acid? Because it is not very costly when compared to the toxicity which the methotrexate can produce. So we can give this folic acid supplementation safely. And if there is severe hematologic reaction, if the severe hematologic reaction, if it is there, then we have to give the leucovorin calcium. We do not have any other way. We have to bypass this dihydrofolate reductase. So we are going to use the leucovorin in such case. Okay. Thank you so much, M, for motivation. Right. And in the hepatic and GI, we have seen that GI nausea, vomiting, diarrhea can occur, and they are going to be reduced. The risk is going to reduce with folic acid. So you can see here the blood, the hematologic problems, and also the GI problems. These two can be taken care of by giving the folic acid to the patients. Okay. Of course, hepatotoxic, this we have already seen. And in the renal, we are going to see what it can produce in the upcoming slides. Okay. And 3 months of drug-free or washout period is important before planning the pregnancy. This is very, very important. Why? Because according to the old guidelines, this methotrexate is a category X medication, category X, and according to the newer rating, it is contraindicated. It is contraindicated. And you can remember 3 months of drug-free or washout period is mandatory. And also it is very easy. You can remember that urine pregnancy test is very, very, very important before initiation of methotrexate in women particularly. Okay. So these are all the adverse effects which you can remember with the help of the simple, methotrexate. The name itself can help you to remember what are the adverse effects. So M for myelosuppression and mutagenic properties. That is the reason why this is, uh, paradoxically, ironically producing certain lymphomas. And E for erosions, we'll see where are those erosions produced. T for teratogenicity, H for hepatotoxicity and hematotoxic, O for oligospermia. T for tired, the patients are going to have experiencing excessive tiredness because of the methotrexate usage. R for renal toxicity. E for exanthem, we have observed that the patients can develop maculopapular rashes, that is exanthem. It is a category X medication, so X. A for abortifacient. So these are the methotrexate. So the last T and E, I didn't find to fill those T and E, but you can remember the other adverse effects related to GI system. Of course, diarrhea, vomiting, abdominal pain, nausea, and ulcerative stomatitis. So these are all the adverse effects. We are going to see one by one slowly. So myelosuppression, the first M, myelosuppression. Please remember this can cause pancytopenia, and we have already seen that this can handled by the help of folic acid. If it is mild, we can take care of this problem, this adverse effect with the folic acid. It can be 1 milligram every day, except for the methotrexate day, or 5 milligrams twice weekly. And because it is going to reduce the pancytopenia problem and also GI adverse effects, this is folic acid administration is going to increase the compliance of usage of the methotrexate. Okay. And it is mutagenic. Okay. And oligospermia, related to oligospermia, sperms reduce in quantity as well as the quality, and we have to advise 3 months washout period before the again rethinking of the conception in the males, and one ovulatory cycle in the case of the females. Okay. This is at least bare minimum once ovulatory cycle, but better to avoid the pregnancy till 3 months after stoppage of the methotrexate medication. Okay. And the next one is E. E for erosions. Where can you see erosions? Where can you see erosions? The gastrointestinal system is going to be affected, and we can see erosions apart from nausea, vomiting. So there can be gastritis, stomatitis can be seen, oral stomatitis, and of course folic acid will reduce these problems, these adverse effects, and so again it will improve the compliance. And mucosal erosions can be seen, and the characteristic finding of the psoriatic lesions, if they are having development of erosions, ulcerations, and if there is bleeding from the psoriatic lesions, then what you should think of? You should think of methotrexate toxicity. And what is the immediate thing which you need to do? You have to stop the methotrexate. Very, very important. So these are the signs the patient is having methotrexate toxicity, and also ulcerative stomatitis, and if the patient is having severe diarrhea. So whenever you see these kind of problems in a patient who is on methotrexate, stop the methotrexate. And what you have to do, you have to think of giving leucovorin. Okay. So this bleeding which we can see also could be because of the reduced platelet levels, which is again a sign of toxicity. So we can see hepatotoxicity. We have already discussed liver fibrosis, cirrhosis can occur. Basically, we can see inflammation, portal inflammation, fatty infiltration, and fibrosis. Out of which fibrosis is the one we decide whether to continue methotrexate or to stop the methotrexate. And yeah, please remember, in malignancies, methotrexate is used in high doses. So that is very, very much associated with the hepatotoxicity. And liver biopsy is the gold standard for identification of this liver fibrosis. And there are various other scores, other blood levels of certain chemicals which are going to help in finding out whether there is liver fibrosis or not. So ELF stands for enhanced liver fibrosis score. We are going to see what it is, and also transient elastography. This is also being used of late. So this is a Renic grading system of the liver fibrosis. You can see that if we do a biopsy and if we find out that there is no any fibrosis, we can call it as grade 1. And if you notice that there is moderate to severe fatty infiltration or portal inflammation, then we are going to call it as grade 2. So till grade 1 and 2, we do not have any fibrotic changes. But in the grade 3A, we are going to have a mild fibrosis of the liver. In the grade 3B, we are going to have a moderate to severe liver fibrosis. Whereas in the grade 4, remember, we are going to have the patient having cirrhosis of the liver. So what you need to remember is, there, apart from the Renic grading for the liver fibrosis, we are having various other ones, like for example, Metavir fibrosis staging. So these are, just remember the names of them: Metavir, IASL, BATS, Ludwig classification, the staging system, Metavir. So these are all the other names. So ultimately, what is the important thing is whether to give the methotrexate, at what levels we can give the methotrexate safely, at what levels we have to stop the methotrexate. We are going to see that in the upcoming slides. Okay. So this is the next one, ELF score. ELF score, in this we are going to see basically three molecules: the hyaluronic acid, P3NP. What is P3NP? The pro-collagen 3 N-terminal peptide, and that is amino terminal of the peptide. So this is one of them, and the other one is TIMP1, tissue inhibitor of metalloproteinases. So these are the three which are the parameters with the help of which we have the score, ELF score system. If it is more than 9.8 in a patient, then we can say that he is having severe fibrosis. So we have to stop the methotrexate if the patient is already on methotrexate, or otherwise we should not start the patient on methotrexate. If the value is less than 7.7, then it is very less likely that the patient might be having liver cirrhosis. So we can continue the methotrexate, or there is no need for the biopsy of the liver. And if it is in between the range 7.7 to 9.8, then it is uncertainty. So we can perform a liver biopsy to check whether there is real fibrosis, yes or no. Yes, the other adverse effects are renal toxicity. Methotrexate we have already seen that it is excreted unchanged in the urine. And remember, there is one variant or one metabolite of the methotrexate, which is hydroxymethotrexate, and this can produce renal injury and also kidney failure. And we have already seen that there is going to be a competition for the excretion through the kidneys between methotrexate and the NSAIDs, and also even the penicillin probenecid. All of these are going to have competition for the clearance through the kidneys. So then if the patient is taking concomitant methotrexate and NSAIDs, which usually the case in the case of the conditions where there is pain or inflammation, in which case the treating rheumatologist usually prescribes both methotrexate as well as the NSAIDs. Then we have to be very very careful whether the patient's kidneys are functioning normally or if there is any problem. We have to identify this. Okay, so yeah, increased methotrexate levels in the blood as clearance is blocked, because of which there is going to be high likelihood of methotrexate precipitation in the renal tubules. And you can remember this methotrexate, it is having very narrow therapeutic index, very narrow therapeutic index. So if there is even small elevation of the methotrexate levels in the bloodstream, then it is going to produce toxicity, which is very detrimental, fatal to the patients. Okay, and in the case of malignancies, for example lymphoma protocol, the dosages are going to be very high, crazy high. So in dermatology, we are going to give at most 25 milligrams of the methotrexate per week. Whereas in the oncology department for malignancies, this is used in very high doses. Even they can give 50 milligrams in a day. Daily dose of 50 milligrams is also being used for the malignancies. So that is the range of the MTX usage in malignancies by the oncology department. So in such cases, they have to maintain hydration maintenance in the patient is very crucial. And they have to think of alkalinization of the urine, because we all know the more acidic the urine, the more possibility of the precipitation of methotrexate. So we have to try to alkalinize the urine. So we can give the bicarbonates. Usually this is not a problem of dermatology, problem of the persons who are using higher doses. Okay, and also leucovorin rescue, we'll see how it is done. And monitoring of the creatinine clearance is also very important, because this will give a picture idea about how the function of the kidneys is in the person. Of course, lung toxicity, the pulmonary toxicity, it can produce initially acute pneumonitis, which is a idiosyncratic adverse effect, but ultimately the patient may land up into liver fibrosis, and also there is a possibility patient may land up into lung fibrosis. Pulmonary fibrosis also important adverse effect. And remember, this is a life threatening complication. And routine screening of the chest x-ray studies and pulmonary function testing are not useful in the detection or prevention of the pulmonary toxicity. So we have to be very careful when we are prescribing the methotrexate in the patients who are already having a lung problem, like for example we have seen in the case of dermatomyositis. Okay, and of course P3NP levels, if it is increased, then we can say that the patient is having the fibrosis of the lungs. And remember, one association of the psoriasis and the lungs, the psoriasis itself can produce the apical lung fibrosis. So in the patients of psoriasis, if you are using methotrexate, then there is very high likelihood of development of pulmonary fibrosis in the patients. And psoriasis can also produce a fatty liver, because it is having association with the metabolic syndrome. So this is a non-alcoholic fatty liver disease associated with psoriasis. So remember these two while prescribing the medication, that is methotrexate, in the patients of psoriasis. So this is the time span from the initiation of the medication and the final adverse effect which can be visualized. So mucositis can occur 3 to 5 days after the initiation of the methotrexate. Exanthem can develop within 1 to 5 days. Hepatitis can be observed within 1 to 10 days of the drug administration. Myelosuppression can be observed from 7 to 10 days of the administration. Renal toxicity can be noted in 1 to 3 days. Can you see this is very, very small time span? So immediately after 1 to 3 days of the drug administration, we can see the renal toxicity features. And ocular irritation can also occur. Ocular irritation can also occur. Why are these days important? Because associated days, we are going to have the investigation, that is the baseline testing for the observing whether there is any liver problem or whether there is any kidney problem. Baseline, we are going to do examinations. Examination has to be done, careful examination, whether the patient is having any pulmonary tuberculosis. All those things should be observed. Investigations, baseline investigation, the CBC should be done, LFT, KFT should be done. And apart from that, what else? Urine pregnancy test, urine routine, man-2 test, chest X-ray. These are all the routine things. But at what time intervals they have to be done? You can remember with the help of this slide, where you can see that renal toxicity can manifest within 1 to 3 days. So we have to also advise the patient to observe any changes happening from the usual routine which the patient experiences. Okay. So this we have already seen. The relative contraindications are obesity, diabetes, renal failure, and concomitant penicillin usage. The NSAIDs, tetracycline, chloramphenicol. Why are these important? The tetracycline, chloramphenicol, because they are going to be in the bound form, the protein bound form. This methotrexate is also bound to the albumin in the more than 50% of the methotrexate is going to be protein bound. If the patient is having the tetracycline chloramphenicol, then it can replace, or it can have more affinity to the proteins, and because of which methotrexate will be in the free form, increase in the possibility of the methotrexate toxicity. Okay, this we have already seen the contraindications. So in the monitoring, remember, we already know the careful history has to be taken. What is the medication history? Medication history. Whether the patient is on any other medications, chloramphenicol, tetracycline, dapsone, sulfonamides, NSAIDs, probenecid. So these all history has to be taken. Proper drug history also is important. Physical examination for any possibility of the pulmonary tuberculosis or any other forms of infections, immunodeficiency syndromes. All of them should be assessed properly. Uh, Identification of patients at increased risk of toxicity. So person is obese, alcoholic, all those things which you have discussed already, they all should be taken care of in the examination. Okay, so yeah, this concomitant medications. Okay, in the laboratory we can do CBC and platelet count. So this is done at the baseline. Why? Because after the initiation of the medication, the patients may land up into pancytopenia. So we have to have a record before the initiation of the medication. That is the reason why we have to do baseline CBC and platelet counts. Of course, liver function test, the transaminase SGOT, SGPT should be done. Hepatitis B and hepatitis C obviously should be done. The because the opportunistic infections possibility is going to increase. Hepatitis B and hepatitis C can also damage the liver. Fibrosis and liver cirrhosis can be produced. Renal function test is also important because methotrexate is excreted 95% in the unchanged form in the urine. Of course, HIV testing is also very, very important. Why? Because immunosuppressed individuals, if you are going to use prescribed methotrexate, then it can further cause immunosuppression, and thereby it is going to lead to unnecessary complications. So that is the reason why, if a person of the psoriasis is having HIV, then we have to not give methotrexate, but we have to advise the patient acitretin. That is a better drug of choice in HIV individuals. Okay, and of course, liver biopsy. Previously, what was the case is, if the patient is having 3.5 to 4 grams of cumulative dose of methotrexate, then it was the norm that we have to perform a liver biopsy to rule out any liver cirrhosis. Okay, but nowadays there are various other measures. Like for example, we have the enhanced liver fibrosis scoring system, in which we use hyaluronic acid, P3NP, and TIMP1. So like that, we have some fibroscan, transient elastography measurements. So all those are used instead of the liver biopsy nowadays. Okay. And in the follow-up, again, remember, we can do the same testing. We can do the same testing, but repeat CBC, CBC and renal function test. And yeah, fibroscan. This is also being used as a a screening test once the dosage of 3.5 to 4 grams of methotrexate is reached by the cumulative dosage reached by the patients. Okay, fine. And yeah. So you can see the investigations. The investigations are done at the baseline before initiation of the medication. And when should we repeat the investigation? That is also very important. So we can repeat the CBC, LFT, KFT. These things can be repeated. The infection screen, which we can, which we do urine pregnancy test, the hepatitis C, HIV, the pulmonary chest X-ray, PAVU, and the MAN2 test. These things can be done once at the baseline, and there is no need to repeat them again and again. Okay, but whenever we repeat the investigation, that is after 1 week of initiation of the treatment, initiation of the methotrexate, and also after 2 weeks, after 2 weeks after the initiation, and after 2 more weeks, and once a month for 3 months. And afterwards, we have to advise the patient to repeat the same investigations once every 3 months. So this is how we can be safe, because there are so many problems. The legal problems, of course, legal problems are also there, but what is more important is patient safety is very, very crucial. So that is the reason why it is better to repeat these investigations in these time intervals after the initiation of the methotrexate, so that if we find out any abnormality, we can follow the protocol to stop the medication, or to do further investigations to rule out any liver fibrosis, mainly. Okay. And of course, quantiferin TB gold can also be done, UPD. These are all the other things. And most importantly, remember, if we have any doubt that the patient is non-compliant, there is non-compliance, the patient cannot understand what in um, uh, like how the medication should be taken, whatever commands we are giving. If the patient is unable to understand or comprehend what are those commands, we better avoid methotrexate. Why? Because we have seen many cases where methotrexate patients were told to take it once a week, but unfortunately they took, some of them took the dosages of 25 milligrams tablets. Instead of once a week, they took once a day. Once a day. Imagine what will happen if they take once a day. So that is the reason why they came after 1 month. We asked them to come after 1 week. Okay, but unfortunately, this usually is a problem of the human error. The basic problem can be from the doctor, the physician, maybe the problem, the patient, maybe the problem, or the pharmacist, maybe the problem, whatever it is. But ultimately, the patient is the one who is going to unnecessarily suffer the problem, or that is a methotrexate toxicity if they take the inadvertent dosages of methotrexate, like 25 milligrams on a daily basis for 1 month or 2 months. They maybe just keep on taking the medication, and once they land up into methotrexate toxicity, they are going to come back to the hospital. Okay, because it is a very cheap drug. That is one side of the coin. It is very good that the patient can buy them, but it is again a problem if they buy it like a chocolate and take it daily. That is also one more big problem. So it is a double-edged sword, I can say. In the safe hands, methotrexate is a very good drug, but in the unsafe hands, this is a very dangerous medication. Okay. So yes, you can see here many clinicians will utilize the fibroscan or as a roughly yearly screening test following a year of methotrexate therapy in the collaboration with a gastroenterologist. Okay, so we can refer the patient to a gastroenterologist so that they can take care of this fibroscan stuff. But usually in dermatological doses, very small doses, usually there is not going to be a big problem. Okay. And liver function test. This is very important. If there is mild elevation of the liver enzyme, that is less than twofold. So the normal levels you should be knowing of the SGOT, SGPT, it is 0 to 50, you can remember. So if there is less than twofold elevation, then LFT should be repeated 4 weeks. It should be repeated 2 to 4 weeks. If there is a moderate elevation, that is more than twofold, but less than threefold, then closely monitor, repeat the LFTs in 2 to 4 weeks and reduce the dose if at all necessary. If there is persistent elevation in the 5 out of 9 AST levels in 1 year, then liver biopsy should be performed, and we have to identify and rule out whether there is any fibrosis or cirrhosis. Okay, and also decline in the serum albumin below the normal range is also very important. Why? Because methotrexate is bound to the serum proteins. 50% of the methotrexate is bound to the serum proteins. Okay, liver biopsy should be performed in such cases when there is decline in the serum albumin. And of course, this you all know, 3.5 to 4 grams liver biopsy has to be done. These things we have already discussed. These are the tables from the Wolverton. So risk factors for pancytopenia. So we already have seen the trimethoprim sulfamethoxazole. It is having action on the same enzymes. I told you dapsone and sulfonamides. Yes, for dapsone, sulfonamides, and dihydroteroid synthetase. So and you can see this trimethoprim and methotrexate. It is going to have action on dihydrofolate reductase. So in such case, wherever there is same mechanism, there is a high likelihood that there is going to be interaction and elevated levels of methotrexate can occur, which can produce pancytopenia and also NSAIDs, because they are the competing for renal clearance. Elderly patients, because of the problem with the reduced renal function, again there is going to be high levels of methotrexate. Avoid. No folate supplementation is a very big blunder. Okay, please remember, pancytopenia virtually never occurred with folate supplementation. Very important. In dermatological doses, the pancytopenia is not a big problem, but folate should be given. Folate has to be given. Otherwise, there is a likelihood that the patient may develop pancytopenia. Okay. Less common risk factors. Daily methotrexate dosage. The daily methotrexate dosage in current era, primary inadvertent given unique once weekly. So what does this mean? Pancytopenia is very extremely rare in the weekly dosages which you are giving, and it can be seen in the cases of daily dosages, that is malignancies. Oncologists are giving this methotrexate on a daily basis. Even 25 to 50 milligrams is given. Okay, in such cases pancytopenia can occur. The rest of the things we have seen that already. Yes, this we have seen: alcoholism, habits. Okay. Yeah, acid-treated. See, concomitant long-term use of both drugs may cause chronic liver disease. You know that retinoids are also going to produce a liver disease. Okay. The other ones are not very important. Yeah, even phenytoin, it is also plasma protein bound molecule, so it can also increase the methotrexate toxicity. Even tetracycline and the other medication, phenothiazines. Okay, that is also, you all know. So we have discussed till now the folic acid, methotrexate, folinic acid, leucovorin. How is it used and where is it used usually in dermatology, folinic acid leucovorin is not much important, but in the cases of the oncological practice, it is very, very important. Even this comes again in the 5-fluorouracil, which we are going to discuss in another video. Okay, so leucovorin. Okay, what is this leucovorin? But before that, folic acid, we'll just see few points about folic acid. It can be used 1 milligrams daily except on the methotrexate day, or it can be given as 5 milligrams twice weekly dosages except for methotrexate day, or it can be given 5 milligrams every day. This reduces the likelihood of the mild myelosuppression. If there is a likelihood of mild myelosuppression, that can be taken care of the folic acid, that is hematotoxicity, and also GI upset and also hyperhomocysteine. The methotrexate can also increase the levels of homocysteine, which can be taken care of by folic acid. So ultimately, this will improve the compliance of the drug intake by the patients. And dosages used in dermatology very, very less, and we give folic acid every day except on the day of the methotrexate. So this will take care of all these problems. But remember, giving folic acid has no effect on the liver fibrosis, the lung pneumonitis, and moderate to severe myelosuppression. Very, very important. Remember, if it is mild myelosuppression, it can be taken care of by the folic acid which we give. But if it is moderate to severe myelosuppression which is occurring, folic acid is not sufficient. We should stop this methotrexate medication, because it is a sign for toxicity of the methotrexate. And then what we have to give the methotrexate toxicity, we can give filgrastim, which is a granulocyte colony stimulating factor. It is going to act upon that, and it is useful for the myelosuppression. And we can also give activated charcoal. For example, if a person by mistake took the methotrexate dose more than or equal to 1 milligram per kilogram, then we can prevent the absorption of the methotrexate by giving activated charcoal, which is going to inhibit the absorption of the methotrexate. And of course, we know the urine alkalinization is also going to improve the excretion of the methotrexate through the urine. Sodium bicarbonate can be used. And remember, leucovorin, which is a folinic acid, it is a derivative of the folic acid, and it is FDA approved to decrease the toxic effects of the methotrexate, mainly on the rapidly dividing host tissues that include bone marrow and the gastrointestinal mucosa. Okay, so and remember, this folinic acid, if we give this folinic acid in the patients who are having malignancy, it was observed that the malignant cells are not able to take up the leucovorin. So the malignant cells are going to be under the effect of methotrexate. That is, cytotoxic effects of methotrexate will be seen. But leucovorin is taken up by the normal host cells, and because of which the methotrexate toxicity will be taken care of by the leucovorin. Selectively, it will rescue the healthy cells. This is what I told you. Okay. And remember, the possibility of the methotrexate dosages can be two. The first one is inadvertent doses. That is, by mistake, the patient uh, was given 25 milligrams once a week, but by mistake, the patient is taking it on a daily basis. So, in such cases, how can we neutralize with the help of the leucovorin? Last methotrexate dose should be identified, or 25 milligrams of the leucovorin, whichever is higher, that is going to be given to the patient. And after that 15 milligrams is going to be given 6th hourly till 2 days, 48 hours. So this is the protocol which is given in case of inadvertent dosages of the leucovorin. But if the patient is on malignancy treatment, this any some protocol, lymphoma protocol, the patient is on methotrexate, then in such cases we call it as leucovorin rescue. Remember, this is what is specifically called as leucovorin rescue. But otherwise, the previous one, that is inadvertent high doses of methotrexate, if they are used, we just call it as neutralizing the methotrexate dose or toxicity. And in the case of the leucovorin rescue, we are going to use 15 milligrams after 12 to 24 hours of the infusion. Okay, that is whatever dose it was given. So according to that, or this 15 milligrams at least is given after 12 to 14 to 24 hours of the infusion. And then later on the dosage is going to be same, that is 15 milligrams every 6th hourly till 48 hours, that is 2 days. So there are so many protocols which I will give you in the next slides, but this is how the leucovorin is available: 50 milligrams per 5 ml, that is 10 milligrams per ml dose it is available. So these are all the values. So okay, ultimately what you can remember is approximately the in the oncology, the methotrexate levels in the blood are also calculated, but in the dermatology we are not going to do that. Okay, in dermatology, because we give very low dosages of the methotrexate. Okay, in such case there is no need to um, investigate for the methotrexate levels. Okay, so if it is 5 into 10 to the power minus 7 moles per liter, then the dose which has to be used of leucovorin is 15 milligrams per meter square 6th hourly for 8 times. For 8 times it has to be given. And as you can see, it is 1 into 10 to the power minus 6 moles per liter. It is going to be 100 milligrams per meter square every 6th hourly for 8 dosages, and 2 into 10 to the power minus 6 moles per liter, it is going to be 200 milligrams per meter square every 6th hourly for 8 times. So broadly you can simply remember that approximately 7.5 milligrams IV is given in the case of mild dosages, hyper dosages of methotrexate, and if it is more, then we are going to 7.5 mg IV per every 3 hours, that is 15 mg per every 6 hours, which the dose which you have seen here, 15 mg every 6 hours. Okay, so this is what is the treatment for methotrexate toxicity. And how to identify the methotrexate toxicity, we have already seen that there is going to be ulcerative stomatitis, very recalcitrant ulcerative stomatitis, and there is going to be the psoriatic lesions becoming eroded and ulcerating and bleeding. So these are the signs of methotrexate toxicity. Okay, very, very important. And what are the resistance or reasons for resistance of the methotrexate? So okay, just know few points. Efflux transporters are going to transport the methotrexate from inside the cell to the outside. They are going to throw away the methotrexate. This is one possibility. Genetic polymorphisms, that is variation in the genes encoding the transporter, this transporter, because of which there is going to be less likelihood of methotrexate being inside the cells. And multi-drug resistant protein. So these are just remember, proteins such as MRPs transport the methotrexate, folic acid, leucovorin out of the cells, So there is going to be, we give the methotrexate, but there is not going to be any clinical improvement in the patients, because whatever we are giving, it is being thrown off from inside the cells to the outside. So how does it act? And what are the routes of the drug administration? So you all probably know this. The topical preparation of methotrexate was available since ages, but what happened is recently the nanoforms are being used. They are coming into the market, because of which we are again seeing the topical formulation of methotrexate, which are used usually in the case of vitiligo. Okay. And we have oral formulations, subcutaneous formulations, which are used without any dilution directly subcutaneously. Even the patient can also take this medication. IM preparation is available. The intrathecal preparation is also available. Remember, methotrexate cannot cross the blood-brain barrier. Okay. Intramatricial, the nails, if they are having nail psoriasis, we can give the the intramatricial injection of the methotrexate into the proximal nail folds, and the dosages usually which are given is zero point 0.1 ml of 5 mg per ml dosages. Okay. And of course, keratoacanthoma, we all have seen that intralesional injection of the methotrexate can also be given once a week. And what are the differences between oral methotrexate and parenteral form is the absorption of the oral form is variable, and it is affected by the food, the milk products in the children usually. And in the case of parenteral, it is consistent and complete absorption. Bioavailability is 70 to 90%, whereas in the case of parental, it is 100% almost. And higher doses may lead to reduced absorption in the case of oral formulations, and no dose limitations are seen as such in the parental form. And gastrointestinal interference can be significant. Absorption is affected usually, and it directly enters the bloodstream, the parental route. And remember, the parental route is having activity and also the toxicity low. Why? Because in that it was observed, parental forms, it was observed that the long chain polyglutamate methotrexate forms are observed to be in increased levels, and the long chain form of polyglutamate methotrexate is having low activity and also low toxicity. This is one thing which you can remember of the parental route. And also remember, if we give the parental route, the nausea, vomiting and gastrointestinal upset, they are observed to be less frequently seen when compared to the oral form. And how do we use this methotrexate? What are the regimes which are used? A single weekly dose is one school of thought, and the other school of thought, which we call it as Weinstein Frost regimen, it says divided doses are better tolerated. And how are the divided doses methotrexate used? So 3 divided doses per week. That is just simply if the patient has to take the medication today, then over a period of 24 hours in 3 divided doses, the patient has to take the medication. For example, if we want to give the patient 25 milligrams per week, then we divide it into 3 forms, approximately 8 milligrams. So 8 milligrams the patient is going to take today morning, 8 milligrams in the evening on the first day. Tomorrow again at 8 a.m. the patient is going to take another 8 milligrams on the second day. So this is how the divided doses are used. Okay, like if it is 6 milligrams, 2 to 2 milligrams will be used. This is called as Weinstein Frost regimen. What is the advantage? The gastrointestinal upset was observed to be less likely when compared to the complete dose being given at once. And what is the disadvantage? Increased risk of hepatic fibrosis was observed with this divided dosages, which is Weinstein Frost regimen. Okay. And what is the general, starting dose? Usually 5 to 10 milligrams per week. And what is the maximum dose we dermatologists use? It is 25 milligrams per week. 25 milligrams per week. And these are the side effects when compared to the chemotherapy doses and the dermatological doses. We have seen this in detail in the slides which were discussed below. And I hope this video was helpful for all the dermatology residents. I believe in giving more than 100% on the field. So before the Viva or theory examinations, if you read well, that is going to help a lot while the examination. You can answer very fluently and also very nicely whatever the examiner is going to ask you. And that is, we can say, if you have done all your hard work on the field, that is before the examination, uh, don't really worry about the result. If there is a good commitment, your result is going to be wonderful. That's rest assured. Okay. And beginners are many, finishers are few, so there may be so many students who will open the Rooks or Wolverton or Bologna or Fitzpatrick, ID, well, whatever book, but there are very few students who will complete the books. Or at least whenever you see any patient, try to complete that particular topic from any one of the books. Okay, don't try to cover all the textbooks, it is very difficult. Or at least if you are having so many pages as your batchmates, try to cover each book by one student and try to what do you say, um, do discussions, group discussions, so that you are going to cover all the books, and you are going to cover one disease from all the books. Okay, these are all the important books. I will leave the links in the description below. And I hope this session was helpful. Thank you so much. Happy Students, happy teacher. How did you feel about this session? If you liked it, please give a thumbs up for this session. And what do you think? Can we have more of these sessions in the coming days? Please put your answer in the live chat or in the comment section below. And what else do you want me to ask? So you can, scan this code and you can join my groups. Okay, if you are UG students, these okay, you can join the crack derma DrMSD group. Otherwise, in the Telegram, you can search for worldwide derma discussion and you can join. If you are a dermatology PG, I will leave the links for the worldwide derma discussion Telegram group in the description below. Thank you so much. The live students who are watching, if you are having any queries, if you are dermatology residents, you can ask those queries in the chat section. If you are having any queries related to Methotrexate and any other suggestions, feedbacks which you want to give me, you can give me personally in the Telegram or Instagram. You can chat with me. Yes, anyone, any queries, any feedbacks, any suggestions. Those students who are watching this session, please do hit that like button, guys. Do not leave this session without hitting that like button, and also subscribe to my YouTube channel if you are new to this channel. Yes, is there anyone who's a PG in dermatology who's watching this session? You can ask me any query or so after 10 seconds we'll call it a day and we are going to stop this live session. So I can see there's no activity. Okay, fine. In the recorded version, if you're watching this video, please put your doubts, queries in the comments, students. We'll again meet in the next class on this channel. So thank you so much for all this patient listening. Happy learning. Bye bye. Thank you so much. Sarve jana sukhino bhavantu. Sarvam Sri Krishna Arpanam. Bye bye.